Thank you.
Thank you.
Yeah, now I invite Dr. Sandeep Grover. He will be presenting on ERG and its clinical applications.
Sandeep is Sandeep is working in. Sandeep is from Jacksonville and working on ERG for several years, and particularly I think his interest is inherited retinal degeneration. Welcome, Sandeep.
Thank you very much. Thank you very much for the scientific committee for inviting me. Can you hear me at the back? Okay. So we're going to talk about a very dry topic that was at the end, which is the ERG. Just curious how many of in the audience actually interpret an ERG. Okay, great. So just to make sure, these are my financial disclosures, but there's no conflict of interest in today's talk. So ERG is a great tool, but it really depends on how it is used. And when do we use it? Sometimes to diagnose particular conditions, sometimes to establish the prognosis, sometimes to kind of monitor the natural history of progression of a disease, especially the IRDs, and then in treatment trials as an endpoint. So sometimes you look at these retinal findings and can make the diagnosis. You really don't need an ERG for this, although sometimes you would do it as a baseline. But when you look at two conditions like this, and these are, the two look about the same, but they are two different conditions. So that's when you need an ERG to kind of establish a diagnosis. So what is ERG? It is basically the light falling on the photoreceptors, and the A wave, which is the first negative deflection, is from the photoreceptors, the rods and the cones. And then the electricity goes through from the outer retina to the inner retina, and that's where mainly the bipolar cells and the Mueller cell gives rise to the positive deflection, which is the B wave. And that's it. That's what ERG is. So dark adapt the patient for 30 minutes according to ICEF standards, and then you stimulate the retina with a dim light flash, and you get this kind of recording, which is totally rod. Then you stimulate with a brighter flash, and then you get the typical A and B wave, and that is rod predominant, although some cones are mixed in it. Then you let the patient light adapt for about 10 minutes, and then a single white flash. You get again an A and B wave there, and which is cones. And then you have a flicker, which is like the disco lights. That's what the patients say. And you get a maximal cone response, several peaks over there. And so basically you're looking at these four kind of ERG recordings to kind of make a diagnosis. So let's go through some cases. 12-year-old boy, unilateral retinal degeneration. Older brother was known to have Stargardt disease. Whenever you talk about unilateral retinal degeneration, always think about trauma, but there was no history of trauma. Vision was worse in the right eye, but even the left eye was slightly down. So that shows you a total retinal degeneration in that right eye. The left eye, relatively speaking, looked normal, although it was not normal. So you do an ERG, the top two are the right eye, the bottom two are the left eye, and dark adapted. So you can see there was hardly a ERG response in the right eye with diffuse degeneration. The left eye had what is called a negative ERG, where the B wave was not there, it was just the A wave. So negative ERG or selective B wave reduction. Of course, OCT makes a diagnosis nowadays, but you still need to confirm it with ERG as juvenile retinoschisis. Another 15-year-old boy, poor vision, poor color vision. You see the atrophic lesion in the macula, some flecks around it. Could be Stargardt disease, could be cone rod dystrophy. So you do an ERG, and what you see is, on the left is the patient and the right is the normal. So if you look at the photopic white for cones, you see the ERG is down quite a bit. You look at the red flicker, and you see the ERG is down quite a bit. So the cones are definitely affected. And then looking at the rods, they're down. They're not normal, but still better than cones. So this condition is described as cone rod dystrophy. This patient had cone rod dystrophy. If the ERG was totally normal, it would probably be Stargardt disease. Another patient, 40-year-old male, night vision problems for a long, long time, side vision issues, other family members with retinitis pigmentosa. You look at the fundus, hardly any pigments. You do have some pigments, but hardly any pigments. The vision was pretty good. The visual field was tubular in both the eyes. And when you do an ERG, you see it was totally extinguished, non-recordable. So the retina looked relatively good, but it established the prognosis that the field and the ERG are both down. This was actually an X-linked retinitis pigmentosa patient, X-linked family. Same, another 40-year-old patient, same retinitis pigmentosa, good vision, and these were the findings. And when you look at this and this, a lot of pigmentary change, mainly along the vascular arcades, better ERG. So you establish a kind of a better prognosis in this patient. And actually, 10 years later, the ERG was looking pretty similar, and the fields were looking similar. So it helped, it helped to establish the prognosis in this disease and to counsel the patient accordingly. 50-year-old, noticing some visual field problems for last 6 months and night vision issues. The retina looked pretty normal. But when you do the fundus autofluorescence, you see these hypo-autofluorescent patches like a ring along the vascular arcades and similar visual field.
1 minute to conclude.
Sure. And you do a light-adapted response. The cone responses don't look too bad, actually. But when you do the rod one on the left panel, it was pretty much non-recordable. And with the bright flash, you see the same negative ERG. You see the A wave, but the B wave doesn't go up. So one of the things to think about is to consider getting retinal antibody panel. Patient was positive on several retinal antibodies, and the diagnosis of autoimmune retinopathy was established, and had a full checkup. Thankfully, this is now 6 months, and so far the patient is negative for any cancer, but he's being followed for autoimmune retinopathy. 6 months, no progression. And the last case, 10-year-old, 1-year history of decreasing vision, poor vision in the right eye, not as much in the left, and ERG was done. The dark adapted response was pretty good. The light adapted was down, so the diagnosis of cone rod dystrophy was made. 6 months later or 5 months later, hand motion vision in both the eyes. Always, always, always think about in a young child about Batten disease, and we did the genetic testing, was positive for PPT1 gene, 2 pathogenic, and so that is why, and that's how the diagnosis is established. It's a fatal condition. So used for ERG in treatment trials. Just want to show we have a lot of trials at UF in the last 1 year.
Time is up.
And thank you.
Thank you for this talk and bringing up this topic. Nowadays, we have the genetic testing and even gene therapies coming in, it is extremely important to diagnose correctly before you go for genetic testing. And when you have a condition like the fundus, which you showed that annular pigmentary disturbance, it's very important that you diagnose whether it's an enhanced S-cone syndrome or it's a road cone dystrophy. Unless we get a good quality ERG, we cannot rule out. Second application, as you shown that heredomacular degeneration, macular dystrophies, you need to know whether it's a cone rod dystrophy or a Stargardt's. Just on when you don't see flex. I'm talking about all these borderline cases. It's extremely, extremely important to have and even for when you have a suspected HCQ toxicity, multifocal ERG is so important. So thank you for bringing up these issues.
So it's not a dry topic, and I think we keep discussing every year. So I run an inherited retinal degeneration clinic, and I insist on doing the phenotype, the pedigree chart, ERG, and correct interpretation, and then I have a genomic test, and finally have a re-diagnosis of the clinical diagnosis.
Exactly. Unless you diagnose your clinically and electrophysiology, your genetic, you can't do the whole genome exome sequencing. You need to be more on a targeted for that particular patient based on whether you are suspecting a best orphanopathy panel or which panel you're going to ask actually. It's very important in these days actually.
The future of retina is going to be gene therapy, even though it's not right now. But for that, we need to be prepared.
We need to understand the electrophysiology first actually properly.
Thank
Thank you, Dr. Grover.